Yeah, good afternoon, everyone. I think at the outset, must thank Dr. Srinivas Kumar to actually create such a platform and have so much enthusiastic crowd available on a Sunday afternoon listening to this. So I think I totally understand that I am standing between most of you and lunch, so I don't want to kind of waste time on a lot of theory and let's try to discuss more practical aspects. So I think pulmonary embolism, as we all know, it's got a very high mortality, almost 20% mortality in 90 days, which is significantly higher than a run-of-the-mill STEMI. And there are various complications like bleeding from thrombolytics or anticoagulation at the outset. There is a high chance of recurrence, and CTPH, chronic thromboembolic pH, it's seen in almost 10 to 15% in a lot of registries. And of course, it entails a lot of psychological complications as well. And the bottom line is the functional limitation of almost 50% at the end of 1 year, which is actually pretty bad compared to a standard STEMI as well. So I'll kind of quickly run through this basically a broad way. It's a little crowded slide, essentially trying to show how to screen for pulmonary embolism. Essentially, there are two very well-established Geneva and Wells criteria, which can be easily employed in the emergency to see if the patient has high risk or high likelihood of pulmonary embolism. And this slide, once the pulmonary embolism is diagnosed, you kind of stratify them into a high risk, intermediate risk, and a low risk pulmonary embolism, based on which the treatment strategy and the decision to admit or not admit depends. So, in brief, essentially, a patient who's got shock, RV dysfunction, or hemodynamic instability in short, they form the high risk pulmonary straight off pulmonary embolisms, which warrant an immediate reperfusion therapy. And the patients who have low risk, essentially whose there is no RV dysfunction, troponins are normal, BNP are normal, they are the ones who fall under the low risk features, in whom you can kind of make a decision to basically discharge from the ER and just go ahead with an outpatient based anticoagulation. So essentially, what is the real world problem? What exactly happens to patients who come with pulmonary embolism? So acute PE is diagnosed most often the ER or in the ICUs, where less likely in the ward. So depending on the primary physician, the cardiologist may get involved. Sometimes the pulmonary medicine doctors are called because patient predominantly has sudden onset dyspnea. Critical care gets involved, or the general physician. And most of the time, independently, a treatment plan is made, whether to be conservative or whether to do some catheter-guided intervention. And in the end, the cardiologists get called again when the catheter-based intervention plan is made. So in the whole process, there's a lot of time that is lost. So the only way to kind of cut short this time is to have a team-based approach, wherein we have a pulmonary embolism response team with so many people involved. And then essentially you realize that different departments have different experience or exposure to pulmonary embolism. Like a patient, like a general physicians may not be seeing pulmonary embolism as often as the pulmonologist or the cardiologist see. And obviously, the comfort with thrombolysis depends from physician to physician. We as cardiologists end up seeing a lot of patients with STEMI, manage them and given thrombolytics without a lot of fear and hesitation. But the same comfort may not be present with a critical care physician who see a lot of bleeding complications with even anticoagulation. And I think another important aspect is the awareness of catheter-guided options like mechanical thrombectomy or a catheter-guided thrombolysis. The lot of physicians don't seem to be aware of it. And most important of all is probably the sinking patient who needs an immediate bailout. Often there is a lot of time lost in a decision making, which needs to be cut short. So to streamline the management delays, we basically the emerging concept is to actually form a PERT team, which includes doctors who kind of involved with the management of PE, starting from cardiology, hematology, even a radiologist is actually available as a part of PERT team to give an immediate and prompt response, which kind of helps in disposing a treatment plan as soon as possible. So this is just a graphic to explain that patients seem to be hemodynamically stable for a significant amount of time despite the presence of RV dysfunction. So even in the setting of RV dysfunction, you may feel the hemodynamics are stable, but they go to this point of no return where once the shock sets in, the mortality exponentially rises. So it's very important to actually catch this substrate of patients who do have significant RV dysfunction but are hemodynamically stable at present. Those are the guys who benefit most with intervening for pulmonary embolism. So this is just another interesting slide. Not only the patient outcome improves as the PERT protocol is implemented in a hospital, the radiology reports also get significantly better. So if you can see the blue bar protocol and the red post, you can see even the radiologist's awareness of what the clinician finds important, like the ratio of RV versus LV significantly improves because the radiologist also gets aware of what the clinical criteria are for our intervention and our management strategy. So most importantly, the length of stay reduces significantly, which obviously brings down the cost. And this is one of the recent meta-analysis, which kind of shows the survival of PERT patients significantly improves despite the severity of in terms of PACE score being the same. And what is interesting is this slide wherein the readmission is significantly better even among patients who were treated in a hospital without the PERT protocol because of the general improvement in the awareness. Again, yeah, this is just a meta-analysis which kind of shows an improved trend in the mortality and significantly lesser length of hospital stay and more use of advanced therapy in terms of mechanical thrombectomy or catheter-guided lysis. So I think I'll just go through a few case examples to kind of describe what we are doing. So this is a 75-year-old lady who had a recent total hip replacement. She was admitted exactly 10 days later with a syncope to the ER, at which time the blood pressure was 80/60. She was tachycardic and the saturation was only 88. So clinically, she had a very high PACE score of 220. It was a submassive pulmonary embolism. There is a high bleeding risk in view of recent surgery. In fact, this is one of the cases which prompted us to form the PERT team and implement it in our hospital. So this patient was seen by the orthopedic surgeon, was called for a cardiology consult. The on-call cardiologist just said cleared for wrote the order of thrombolysis if cleared by orthopedic surgeon. And the orthopedic surgeon said thrombolysis if cleared by cardiologist. So there was a kind of tug of war in the emergency and finally nothing got done. It was the next day when the matters got escalated and then things were kind of discussed in a multidisciplinary way. And we felt that the patient would possibly benefit from a catheter-guided lysis where you can kind of reduce the dose of thrombolytic therapy and watch for complication, at which time you can immediately stop the treatment. So this is the CT of the patient where you can see a significantly dilated right ventricle compared to the left. In fact, the RV by LV ratio was almost 1.2. And there is a saddle embolus in the main pulmonary artery, which is extending to the right and the left side, including to the lower branches. So this is the echo. Forgive me for the poor image quality. You can see a significantly dilated right ventricle compared to the left. I got a better picture of a McConnell sign in the coming up case examples. And you can also see the D-shaped septum. And there is an RV dysfunction in the form of a TAPC of 1.4 and a RV TDI of only 9.7. And this is the initial pulmonary angiogram with a 6F pigtail in the main pulmonary artery. You can see a significantly reduced vascular markings in the right mid and lower zone and the left lower zone. And there is some filling defect noted in the proximal right pulmonary artery. This patient received a 5 mg bolus tenecteplase followed by a 1 mg per hour infusion for 18 hours. There was a significant clinical improvement. So you can see the one on the left is the echo prior to lysis and the one on the right is the echo within 24 hours. There is this remarkable reduction in the size of the right ventricle with very visible improved functioning of the right ventricle. And this is the TAPC, which was 1.4 to begin with, had come to 1.7 and RV TDI of 9.7, which improved to 13.7. All this within a span of 24 hours, mind you. And the mean PA pressure had reduced from 29 to 12 in the cath. So this is another case of a 28-year-old gentleman who had absolutely no risk factors, came with 2-day history of dyspnea. He had mild hypotension, BP was in the range of 90/60 and was tachycardic at presentation, saturation was 90%. This was the CT at CT pulmonary angiogram, which showed a significantly dilated right atrium and right ventricle. And there is a thrombus mainly involving the left pulmonary artery, left main pulmonary artery. And the distal right pulmonary artery and the right lower lobe arteries were also significantly occluded with the thrombus. And this is a very classical McConnell sign where you could see a free wall hypokinesia with preserved apical contraction and massively dilated right ventricle and right atrium and possible thrombus in the pulmonary artery. and the plaques view showing significantly dilated right atrium and a very classical D-shaped septum compressed by the dilated right ventricle. PAPSI was 1.4 to begin with, and his TR gradient was around 50. So this guy fell into a high-risk PACE. Anything more than 110 is considered high. PACE score was 132 with significant RV dysfunction. His troponin was also mildly elevated. But then again, he had no contraindication for thrombolysis, so we went ahead and gave him a full dose of IV tenecteplase. And within 24 hours, there's a significant clinical improvement. He was off inotropes and oxygen, and he was discharged on oral apixaban. We did not do a repeat angiogram. So as you can see, I have actually kept the annotations on this slide to just demonstrate. So this was done at around 3 a.m., which shows almost like a McConnell sign. And this was done exactly 20 hours later after thrombolysis. So within 24 hours, there was a significant reduction in the size of the right ventricle and improvement in the function of the right ventricle. So forgive me, the scales are different, but essentially the TR max of 50 had come down to 33 at the end of lysis. And you can see TR is also minimal, and the RV TDA had improved to 15.8. And this patient was essentially discharged in 3 days out of ICU within 24 hours. And this is, I think, a pretty much a challenging case. A 64-year-old lady who was recently diagnosed with CA cervix. She was on chemo and radiation. Last chemo was received 7 days prior to presentation. She had loose stools for 4 days, following by sudden onset dyspnea and chest discomfort for 1 day. At the time of presentation, her troponin was 2,300, D-dimer was 8,500, BP was 80/50, pulse rate of 144, and most worrying factor was it was immediately post-chemo, the platelet counts were only 39,000. So here we have a lady with echo showing RV dysfunction and a high PACE score, who is a definite candidate for immediate reperfusion therapy. At the same time, she has contraindication for even use of heparin. So literally our hands are tied. So this was because she was sick and sinking, we had to take a decision. So we took her for an invasive mechanical thrombectomy. So this is a selective pulmonary angiogram on the right and the left side. As you can see, a clear filling defect in the right main pulmonary artery and paucity of arborization in the upper and mid zone vessels. And there is also a filling defect in the right left pulmonary artery. So in fact, we had to kind of improvise and use over-the-shelf items too, because the penumbra was going through a change in the distributorship in Hyderabad, and it was catheters was just not available. So we actually just took a regular long sheath and used a end-hole catheter, multi-purpose in GR, and we connected it to the penumbra system and completed the mechanical thrombectomy in this patient. So how is penumbra different from just a regular syringe aspirate? So this graphic clearly demonstrates that when you actually aspirate using a syringe, the vacuum falls within the first 15 to 20 seconds. It almost becomes zero. But penumbra kind of gives you that sustained negative pressure, which helps in aspirating the thrombus more efficiently. So subsequent care, this patient was off inotropes and CPAP in the next 48 hours. She had stable renal parameters. We actually started transfusing platelets to maintain it above 50,000 to enable giving a heparin to her. She had wide fluctuations of APTT with unfractionated heparin, so we kept her on enoxaparin. And we did not consider catheter-guided lysis because the platelets were under 1 lakh, and that's a contraindication. So actual plan was, if the patient's platelet dropped further and we are unable to give enoxaparin, we'd probably just place a retrievable IVC filter and discharge. But thankfully, in few days, the platelets improved and we could actually discharge her on anticoagulation. So in conclusion, I think these three cases kind of demonstrate the various varied presentation and therapeutic options in patients with pulmonary embolism, and rapid reperfusion is essentially indicated whenever patient has cardiogenic shock or RV dysfunction on echo or on biomarkers. Team-based approach any given day gives a faster and a uniform decision making, and catheter-guided interventions when needed in the form of mechanical thrombectomy or CDT. Yeah, I think this is very important. I found it very interesting, especially in treating PEs when decisions are probably more important than incisions. So I'll be happy to collaborate if or help if somebody is willing to set up a PERT team at their respective places. Thank you.